and this is going to be just the quick view into the urology. If you will have any questions during the presentation, just ask me. If I will knew the answer, I will love to answer them. So all of the information which are in this presentation are from the guidelines. We've got every year new guidelines from the Urological Association, European Association of Urology. These one are the latest, and the definition of the infertility is the failure to achieve a clinical pregnancy after 12 months or more of regular unprotected sexual intercourse. What do you think? What does mean a regular unprotected sexual intercourse? The definition. It's like one in a month, every day, twice or 3 times a week. Thank you. And we clinically we divide it into the primary infertility. That means that the parents never had the children, and the secondary, when the parents already had the children, but now they cannot have another one. Even though that we examine both of the parents, we 20 to 30% of their infertility is unexplained. And please remember it for your clinical practice. Always investigate both of the parents together, because we had a case which is quite sad, because the couple came to our clinic that they already had 4 cycles of the IVF, and they decided to change the clinic, and we realized that the man doesn't have testicles, and we're like, how is this possible? And they said, and the guy said, they never examined me actually. And we're like, what? How is this possible? So always you have to always start to investigate both of the parents. It's also in the recommendation. Etiology. In men, it's failure of the sperm production or the failure of the sperm delivery. Etiology, as we said, it's in 30% idiopathic. In 15% is the varicocele. Varicocele is a dilation of the veins. You've got the men's gut in the scrotum. They are called plexus pampiniformis, and because of the dilation, the blood is coming back to the testicle. There is a reflux, and the blood is there. Then the blood is more warm, and there's also hypoxia. So that's one of the reason we think that that's the reason of the infertility. So, but the varicocele is in 15% of normal population of the male, even though they are fertile. It is in 20% of the semen analysis, but we know that the 35% people, 35% men with the infertilities got the varicocele. But it doesn't mean you've got the varicocele, we can solve it, you're going to be fertile. It doesn't work this way, unfortunately. And one more really important thing, when we do the procedure, I will show you the video later. When we treat the varicocele, we have to wait at least 2 spermatogenic cycles before we test if the surgery was done right or not. Do you know how long does take the spermatogenic cycle? Sorry? I'm sorry. Yeah, it's around, we are saying 36 days, so perfect. Thank you. Another etiology is hypogonadism. That means that there is a problem with the production of the testosterone, or the problem with the production of the sperms. Maldescent testis is also quite common etiology, and there is more another etiologies, of course. For example, cancer. If the male got a cancer in his young age, he can be infertile then. So the workup. Man comes to our office, and first thing we do, we take the history from him and the risk factors. First one is the cryptorchidism, or the undescent testis. second one is the testicular torsion or trauma before. Do you know what is testicular torsion? It's when the spermatic cord twists, the testicle twist inside of the scrotum. It looks like this when we do the surgery for imagination. This is the penis. Here are the testicles, and this one was rotated, so we have to derotate it. You always have to take the patient to the surgery field. You cannot do it just like on the outpatient. This is the case of the torsion when the man unfortunately came late. Usually we say that you have to operate the man till 4 hours. Okay, cancer. Again, here we can see the ultrasound. It's like the ultrasound is like the best friend of the urologist. We are using ultrasound for every organs we care about. And here you can see this dark. Yeah, we don't say it is dark. We say it's hypoechogenic lesion. And when we operated this patient, this is his testicle. So we could see already that there is a tumor, and then we sent always to the histology to know exact type of the tumor. Yeah, and another risk factors is the genitourinary infections, especially STDs, and exposure to the environmental toxins. One thing we always have to ask the patient is if they don't use any anabolic drugs in the gym. Why? If the men are using constantly testosterone, supplement them, they suppress their natural production of the testosterone because of the they decrease the levels of the gonadotropins. So we always have to ask about this. Physical examinations, that's the second step. My colleague in work, when he teach our medical students about the infertility, always says as an example Peter Griffin. Do you know him? Do you know Family Guy? Unfortunately, this is the typical patients. Usually, when a couple comes, the patients aren't the young, healthy men. It's usually men who looks like this. They are coming in clothes, not naked, but usually it's the men who are overweighted. So we always have to look for his waist circumference. Then also we have to check his secondary sex characteristic. Do you know what is it, for example? Yeah, for male. For example, pubic hair. Yeah, the jawline is and things like this. Okay. We also have to exclude gynecomastia. That means that there is a hypertrophy of the breast gland. And we always have to check up on the penis, on the size of the penis, hypospadia, and angulation. What is hypospadia? It means that the urethra, the opening of the urethra is not on the tip of the gland, but it's somewhere on the ventral part of the penis, which is a problem because when the man who's got the hypospadia in this way, even though he ejaculates, the sperm won't get into the vagina of the women. Also, the angulation is a really big problem because you can see if the man's got erection, the sex is not possible in this way. So usually when the angulation is on the ventral part, it's usually congenital. When it's dorsal part, it's a secondary disease called morbus Peyronie. Next thing we always examine are the testicles. Of course, we always check for the size, if there is no pathological expansion, or if the patient is not after orchidopexy. That means that when the patient had the Maldeston testis, we can do the thing that we fix the testicle inside of the scrotum. It's called orchidopexy. Also, we have to have to check on the epididymis and to exclude the varicocele, as I told you. there is a one genetic mutation which can do the absence of the vas deferens. We will talk about it later, but it's important to always check if the patients got both vas deferens, and we are also providing the digital rectal examination. Scroll to ultrasound. As I told you, it's like ultrasound is our best friend. We always measure the size of the testicle, homogeneity of the parenchyma, and the vascularization. Here we can see the varicocele. The colors means that there is a blood, and usually the veins should not be dilated more than 3 millimeters. This is like the typical picture of the patients who's got the varicocele. You ask them to breathe in and hold their breath, and when they are higher the intra-abdominal pressure, the veins, the blood from the veins go back to the testicle. Okay, and always, that's actually quite a new thing. According to the guidelines, you have to provide ultrasound also, because there are two papers which says that the men who suffer from the infertility has got higher risk of the testicular cancer. So you always have to provide this ultrasound and exclude the testicular cancer. Next thing we are using is the semen analysis. That's the thing you know much better than us clinicians. But for us clinicians, it's always important to have more than one sample. And it's really important to say to our patients that when we want the specimen, they have to have sexual abstinence for minimum 2 days, but maximum 7 days. Here are the numbers which are right now in our guidelines in the year 2024, when I started to study medicine, which is not so long ago. The numbers were different, and it changes every year. But the methods of the IVF getting better every year, so that's good. Something what is really new, and we are talking about it on our conferences now. In always when we've got some andrology part of the conference, is DNA fragmentation. It is also now already is a strong recommendation to check the DNA fragmentation. It can be according to lifestyle of the patients, according to smoking, for example. And if we are not sure why the male is infertile, we should always provide this test. Also, we have to check the hormones if they are in a normal way, because when the hormone levels are low or high, we have to check for the hypogonadism. Next thing we are doing is the genetic testing. It's not a routine test. We are doing it when we still don't know why the man is infertile. Here you can see what we want as a clinicians, what we write to lab technicians, what we want to see. What is this one? Karyotype of what? Huh? Yeah, and what's the wrong about this karyotype? Perfect. Klinefelter syndrome is one of the most common cause of genetic of the male infertility. Right. Okay, so now we know what happened to what's the problem with the patients, and we've got some management. When you are reading the guidelines, there is always first conservative therapy, then the surgery, then the IVF. But we should not think about it like first line therapy is the conservative, then we go to surgery. It should be considered as a complex problem. And for example, if the patient's got varicocele, we don't try some vitamins and antioxidants and then we go to the surgery, we go right to the surgery, or we can do this kind of therapy simultaneously. Okay. Conservative management, we have to treat, if there is an infection, we have to treat the infection. We also have to say to the patient that they should do some changes in their lifestyle. For example, in obese patients, there is a big problem of low level of the testosterone. Do you know why? In obese patients who's got a lot of fat tissue, they can have a lower level of the testosterone. Amazing. And do you know the name of the enzyme? Aromatase. Sorry? Aromatase. Yeah, amazing. Perfect. And also, we have to educate them about the quitting the smoking because of the higher oxidation stress of for the cells. And if there is a problem with the hormonal levels, we are providing the treatment of the hypogonadism. Please, if you will ever meet a patient who says, I've got low testosterone levels, sometimes what we can see from another colleagues, they prescribe them testosterone. And say, okay, that's great. I will prescribe the testosterone at really high levels and it's going to be great. Why won't we do it? No, is the thing I told you in the start of the lecture. When you prescribe synthetic testosterone, you will just flare up the normal testosterone which is produced by the testicles, and you won't solve the problem. The problem is that the patient don't produce his own testosterone, so we have to not give him the testosterone, but for example, give him gonadotropins and treat the problem. Some surgery things. That's actually what we as a urologist do, and this is our most favorite part. The first one is the varicocelectomy. Usually we are using this inguinal approach is the best one, and we are using mostly we are using a microscope. Here you can see a video from the surgery from our department. This is, can I stop it? No. This is the spermatic cord, just for your imagination. Yeah, you cut the inguina, and then you get the spermatic cord, and this is the spermatic cord. So, first thing you have to do, you have to find the veins which are dilated. Here you can see one. You have to always preparate them, clamp them, and cut them. When you clamp and cut the vein, you won't have a reflux of the blood back to the testicles. What's problem of this surgery? What we have to be aware of? What's our another thing in the spermatic cord we can find? They're not just veins. Nerves, yeah? Sorry? Ductus deferens. It would be bad if you would cut the ductus deferens. And something else? You already said veins, right? Nerves, ductus deferens. Musculus cremaster. In this level, no. You already cannot find it here. Actually, it's this one. It's an artery. Yeah, sometimes we've got the problem that the patients come from another center, and they said, "Oh, I had the surgery for varicocele, and now I have a pain in my scrotum." And you provide the ultrasound, and you said there's no blood. like, okay, and then you realize that the artery was cut. So you always have to check that the artery, you see it, you can use mini Doppler ultrasound, or you can see it under the microscope, that the pulsation of the artery. That's the reason why we always do it under the microscope. And unfortunately, there are still centers in the Czech Republic which do it just by their eyes because they are saying, "Oh, I can see it; it's okay," but it's off-label. Now, you always should use microscope during the surgery. You can have a special glasses. That's the true, but we usually use a microscope. That when there's a microscope, there's the operation field, and you've got microscope, and then you know this oculars. So 2 or 3 surgeons can look into one microscope. It have to be covered in sterile foil, but it's as I told you, the artery, you always see the pulsation. Vein doesn't have a pulsation because there is a much lower pressure. And also, when I provided the surgery for the first time, I was like, oh no, it's a mess. I cannot see anything. But after you do some more procedures, you can see slight differences between the tissues. It's same like in histology, for example, when we first saw some samples, everything was pink or purple, and now you can see everything. The next method is MESA-PESE methods, and the first thing we are doing is the aspiration of the sperms from the epididymitis. But sometimes there is not an obstruction in the epididymis, so we do the testicular sperm extraction. It's done by the cut of the testicle. We cut it by the scalpel, and then we mechanically pull the tubules from the testicle and cut some of them. Then we also, when we provide this type of surgeries, we always have to contact our lab technician from the IVF center. They are with us on the operating room. They're waiting for the samples, and then they always go to the lab immediately and try to look if there are some sperms or not there. Even though before we finish the surgery, they are already calling us if there are some sperms or not. So it must be a quick procedure. And also one funny story, and it didn't happen once. It happens like every 3 to 4 months. The couple comes to our clinic that they are infertile. They've got a problem to get a baby, and then you ask the husband just like a quick question, like, didn't you have any surgery? And no, I didn't have. I had a vasectomy with my first wife, and we were like, okay, so maybe that's the reason. What we can do is vasovasostomy, when we can connect back the ductus deferens, but there is a problem, and we always have to inform our patients who are going under the vasectomy that the chance that we can reconnect the ductus deferens is only 50%, and the best results are until 5 years after the surgery. After 5 years, there is a lot of fibrosis, and after 10 years, we don't try at all because it's impossible to reconnect it. So that was something from the surgery. Do you have any questions?